Good morning. Today we'll continue with gross anatomy of the abdomen and pelvis. We have looked at the peritoneal cavity. I think you've had 3 or 4 classes. I believe my last class was not able to beam for whatever reason. I was supposed to cover greater sac and lesser sac. I hope you've caught up with it. I think other teachers would have touched upon it. So we will launch into the organs which occupy the peritoneal cavity today, and we will start with the spleen. Alright, so I think all of you have already a little idea of what the spleen is, where it is, what it does. You might have heard of a malarial spleen, particularly in a country like India, where malaria is endemic, and the spleen does filtering of senescent RBCs. So dying RBCs go to the spleen, it's the graveyard, and that is why taking the huge load of dying RBCs in a disease like malaria, the spleen enlarges. So I'm assuming that everybody in the class has heard of a splenic enlargement and of certain diseases which are associated with it. Apart from that, already we finished the histology or the microstructure, and if you remember, we had done 4 lymphoid organs, and out of them spleen was the hemolymphoid organ. So we'll touch upon that for a second, but mainly today we will look at the gross anatomy, that is the morphology, the gross organ which you can see and feel, which you will come across as a content, an intraperitoneal content of the abdominal cavity. This is what it looks like. It's an odd shape. It is very, very variable shape. In this case, it's looking somewhat like a triangle, maybe. Okay, and it has a outer surface which is more convex and which will fit into the palm of your hand, and an inner surface which will show where the vessels are entering and leaving, and this part is called the hilum of the spleen. So it's a hemolymphoid organ because it filters the blood and therefore any microorganisms that are contained in it. But before you were born, it is also a place of manufacturing of your blood cell lines, particularly the erythrocytes. After birth, it continues to manufacture lymphocytes, which is why we put it in the group of lymphoid organs. Very vascular, therefore it is friable, but it is slightly elastic. It's purplish red in color, moves with respiration because it is tucked in the left hypochondrium under the left dome of the diaphragm. So every time the diaphragm moves up and down, the spleen is mobile within the peritoneal cavity, and also it has excursions with your breathing. The parenchyma may regenerate after partial removal. It's a high metabolism organ, and it's described because it's a solid organ. It is described as having a shape roughly oblong and an axis which is oblique, directed downward, forward and laterally, coinciding with your left 10th rib. In the upper left part of the abdomen, so on the one side is the stomach, which is also upper left, and the diaphragm, which is also upper left, and this is tucked into the gap between the two. So it will, in terms of quadrants, it will occupy the left hypochondrium, and partly in the epigastrium is actually wrong. I think that please do not count that, because epigastrium is here and spleen is definitely only in the left hypochondrium. Sometimes if you're standing and it's a long thin abdomen, it may just encroach into the left lateral region, but only if it's very, very much enlarged. Otherwise it's under protection of the left costal margin, therefore it will stick entirely into the left hypochondrium. It is roughly wedge shaped. In the previous slide it was described as oblong. It is a little variable. It is subdiaphragmatic in position. It's important for you to start orienting yourself with the transverse sections through the abdominal cavity, just as we had done in the thorax. So here again is a typical view which is comparable to a living anatomy diagnostic view from your radio diagnosis investigations. So there you'll have the vertebral column on the top and the anterior abdominal wall in the front, and this would be the liver on the right of the patient, and the spleen on the left of the patient. So where it is right now is tucked in with the stomach on this side. This section is below the level of the diaphragm, so you don't see the muscle at all, and you're seeing the left kidney on that side, and this is the body wall with the ribs. So into that gap is where the spleen is tucked, and you have the tail of the pancreas coming right up to it, and a bunch of peritoneal folds which are associated here. I hope you have revised that there was a lesser sac. So the most left extreme of the lesser sac is abutting on the hilum of the spleen, and that is where you get the ligaments, the peritoneal folds, which reflect off and appear to connect spleen to stomach and spleen to left kidney. If we projected the spleen onto the body wall and looked at it from behind, this is where it would be under protection of the 9th, 10th, 11th ribs. And if you look at it from the side, you see that it is its long axis, which is oblique and downward and anterior, is exactly like the axis of the left 10th rib. This is what it looked like. It is again a diagrammatic view, but this is roughly the shape and the shine and the consistency and the color. So we describe it as having an anterior posterior extremity. In many books it's rather called medial end and lateral end. So we'll follow that. And definitely in all books there is a superior border and an inferior border, a diaphragmatic surface and a visceral surface. So those two are absolutely correct. But whether the ends are medial lateral or anterior posterior is a interpretation phenomenon. You follow the textbook whichever you're following, and I will repeat it here. On the visceral side, on the inside, what we will see is it seems to be indented, and this is because of the other strong organs which are abutting on it. They have left impressions on it. So we have at the hilum the entry of the splenic artery vein, and we have between this border and that border some indentation. So there is one which for the stomach, gastric surface, there is one for the kidney, renal surface, there is one for the colon, the left flexure of the colon, and somewhere here there will be the relation of the tip of the or the tail of the pancreas also. It is about 1 inch thick, 3 inches wide and 5 inches long. Its weight is about 150 grams, and its surface anatomy is behind the 9th, 10th and 11th ribs. So this was put together as a rule of odds by a person called Harris, that 1, 3, 5, 7, 9, 10, actually leave 10 between 9th and 11th ribs. So all these odd numbers are the way to remember the dimensions of the spleen. So it's small here, it's just tucked right in here. The left lobe of the liver in this case seems to be coming all the way up and overlapping, but you must remember liver is very anteriorly placed, abutting on the anterior abdominal wall. Spleen is posteriorly placed, so technically they have no relation to each other. They look as if they are touching. Please remember this. What is touching the spleen is stomach and left kidney and tail of the pancreas, and this one, the left flexure of the colon, goes right up to here and touches upon it. So these 4 organs, if you remember, that's good enough. But remember the dimensions in this way. Presenting parts, and the spleen is dead, it doesn't present anything, but that is the way we describe it. When you hold the organ in your hand and you're describing it in the practicals to anybody, we say that these are the things which are presenting to us, which are visible to us. So the 2 ends are medial end and lateral end. We saw in the previous one, it's called anterior and posterior. Now medial, you must remember, is the one closer to the vertebral column, and lateral is the one away from the vertebral column, right? So that lateral end is more anteriorly placed because it's in the curve, on the lateral curve of your body. So the medial one is posterior and the lateral one is more anterior placed. 2 surfaces are easy: diaphragmatic, which is convex, which is right against the ribs, and visceral, which is coming across, which is touching the other organs. 2 borders, superior, there's always a superior border and an inferior border, and this in-between place where the hilum is, where the vessels are entering and leaving, is described as an intermediate border because it's also a projection from the surface. It's a very blunt projection. And 2 angles, anterior basal and posterior basal, we will look at that. But if you remember, one thing to remember is that the medial end is more narrow and the lateral end is more wide, seems to be more wide. And the superior border has got notches, whereas the inferior border doesn't. These are the 2 points by which you will be able to put the spleen in the correct anatomical position. When you see it, you try to describe it. So again, this would be the lateral end or anterior end. This would be the medial one because it's narrower. There'll be now he's calling it anterior border and posterior border. This is a very ancient diagram from one of the earlier editions of Gray's Anatomy. You please write it as superior and inferior border because that's the easiest way to remember, and it's always, even if it's obliquely placed, the border on top is more or less above cranial, and it will have these notches. That is how you identify the superior border and then the inferior border. And then you have this intermediate border where you have the veins and arteries on it. So the anterior or lateral end is broad, downward, forward, and almost never crosses the mid-axillary line. So it doesn't come more anterior than that. Okay, so probably best to call it the lateral end. Then the medial end is rounded upward and backward and towards the vertebral column and almost rests on the upper pole of the left kidney. The borders I've mentioned, the surfaces I've said, diaphragmatic is convex and smooth, visceral surface is concave and rough because it is marked with several organ impressions. The anterobasal angle is the junction of the superior border with the lateral end. Which one did we say was lateral? That was the medial end. So this is the lateral end. So this would be the anterobasal angle and this would be the posterobasal angle. And this anterobasal angle is the one which will become palpable. On the visible surface, we have on the visceral surface, we have the gastric impression for the stomach, for the fundus of the stomach. And then you have a renal impression for the upper pole of the left kidney. And you have a colic impression for where the transverse colon is becoming the descending colon. That's called the left colic flexure. So these are the structures which are abutting on the spleen in life. And a pancreatic impression may not form much of an impression, where the tail of the pancreas comes almost in touch with it near the hilum of the spleen. So the visceral surface is described as having 4 impressions. This superior border separates that gastric impression from the diaphragmatic surface. It's thin, convex, has 1 or 2 notches. And these notches are there because in development, the spleen developed in several pieces, 5 or 6 separate splenic material, tissue, which fuse together and then form the final spleen. So this notching indicates that there might have been separate parts which fuse together, and this is one way of recognizing the superior border. The inferior border is close to the renal impression. So on the visceral side is a renal concavity, and then there is the diaphragmatic convexity, and this is called the inferior border. The angles I mentioned, the most forward projecting part is the anterior basal angle. It should be looked for in the 9th intercostal space, somewhere near the mid-axillary line. Usually in health it should not be palpable. A healthy spleen is not palpable. But when it gets enlarged, usually due to some disease, some challenge, then it becomes palpable under the left costal margin, and this is therefore called the clinical angle of the spleen. What you will first feel in the patient, some organ coming and touching your finger, that would be the anterior basal angle of the spleen. And the posterior basal I've already described. So that is where it is tucked in. If you remove the stomach, here from here, esophagus, you've cut it at the lower end of the esophagus, you remove the entire stomach, you've removed the vessels which are coming to the stomach, and this end of it we haven't even seen at all, so duodenum must be somewhere there. And you've laid open the bed of the stomach, behind the stomach, whatever is there. And there you will see that there will be a kidney somewhere which we're not seeing, on top of which is the left suprarenal gland. And you will see the body and the tail of the pancreas, and you will see vessels coming to the spleen, all covered by the posterior surface of the lesser sac. So this is the behind the stomach story, which is only revealed when the stomach is completely removed. And you see that other things, the transverse mesocolon is extending here and the vessels are going within it. What you will need to do is peel off that posterior surface of the lesser sac, the peritoneal sheet, to reveal the vessels entering into the spleen. So here therefore the purpose of showing this picture was, now you see that the curvature of the stomach fundus is what has pressed upon the spleen and therefore given it its gastric impression. And then you have this superior border which has got some notches, and you have this lateral end, right, or the anterior basal angle, and then you have the medial end or the posterior part. It's more medial than posterior, and this is more lateral than anterior technically if you put it in anatomical position, but it is slightly oblique, so you can call it both. Then we have the relations. These are very important. So the spleen is completely covered by peritoneum of the greater sac. We saw that on all sides, except at the hilum, where between the two sheets the vessels are coming through. So it's attached and related to the gastrosplenic ligament. This double sheet is connecting the greater curvature. The greater curvature of the stomach is like this, right? It's like that. So between that and this there is a double sheet of peritoneum, and that is called the gastrosplenic ligament, in which the vessels will come. Vessels which are branches of whatever is within that ligament. And then you have the lienorenal ligament, which is the posterior surface connecting the upper pole of the left kidney to the spleen. So there are two different sheets. And then you have a phrenicocholic ligament, which is a separate thing because the transverse colon is here. So between the transverse colon and the spleen, the fold of peritoneum is notching basically to the undersurface of the left dome of the diaphragm. The colon is being kind of hitched there between the parietal peritoneum and the covering of the transverse colon. There, this peritoneal band or fold is there called the phrenicocholic ligament. So when it is in anatomical position, the gastrosplenic ligament is this one, this plus this together, the double sheet in which the vessels are lying. And then you have the lienorenal ligament between. We opened out that sheet, we peeled off this. You're revealing the upper surface of the left kidney by peeling off the peritoneum which was covering it, and where the kidney is abutting on the spleen and containing these vessels is called the splenorenal ligament. And the attachment of the transverse mesocolon is here, and it extends right up to the diaphragm. It goes behind the spleen or under the it. Can you see this? This sheet is from here to here, and it's going underneath the spleen to hitch, to be attached to the parietal peritoneum there, and that should be called the phrenicocholic ligament, right? Phrenicocholic ligament. It's actually got nothing to do with the spleen. It's not a reflection of peritoneum on the spleen, but it is a fold which is not allowing the spleen to go further down below it, because it is attaching the transverse colon to the diaphragm. So that is what we wanted to show, and I wanted to show you how the left kidney is related. Here will be the left adrenal. Here is a suprarenal gland. This is the stomach. That in the previous picture we cut it at the esophagus. Now if you cut it through the upper part of the stomach, you see this is the whole stomach relation. Stomach is much bigger and completely overlaps. You don't see the spleen unless you remove the stomach. You remove the boundary of the lesser sac. Then you reveal the structures which are very closely related to the visceral surface of the spleen. The left kidney upper pole, the tail of the pancreas, the splenic flexure or left colic flexure. So when you take it out, we have to remember how it used to be in situ and therefore recollect whatever is related to it. The diaphragmatic surface is easy. There, because it is just under the diaphragm, and we know that the lung comes down right up to the costal margin, the costodiaphragmatic recess of the left pleura will be related to the spleen. Also the inferior-most part of the left lung, and the 9th to 11th ribs of the left side. These are the relations of the diaphragmatic surface. On the visceral surface, we will see there is a gastric surface, so the stomach is related. The short gastric vessels will be inside the ligament, gastrosplenic. Renal surface, therefore, upper pole of left kidney. Splenorenal ligament containing some vessels. Splenic artery and vein. Left gastroepiploic vessels within the lienorenal, and the other viscera which are related are the colon itself, and this area near the hilus is where the pancreas will be related to the spleen. So again, a little bit out, because any of these can be asked as a singular question in which you have to know where it is and what does it do. So the gastrosplenic ligament, what it does is connects the fundus and greater curvature of the stomach to the hilum of the spleen, and the lienorenal from the lower border of hilum of spleen to anterior surface of kidney. This is a difficult diagram. It's a line diagram from one of your smaller books, but the point of showing it was that in the gastros, this is stomach, right? And that is its lesser curvature, and that's its greater curvature. And from here to here, some vessels are going. They're going to the spleen. They're actually coming away from the main vessel here. But the point is, the vessels are contained within this gastrosplenic ligament, and they're called the short gastric arteries. Then between the kidney and the spleen, this double sheet from here to here is the lienorenal ligament, which also contains some vessels. They're very close to each other. So this to this is the lienorenal. This to this is the gastrosplenic ligaments. The contents are the short gastric vessels for gastrosplenic ligament, left gastroepiploic vessels, lymph nodes, lymphatics, and sympathetic nerves. Very important ligament, because if we are going to disturb it for any reason by doing any operation or any exploration in the left hypochondrium, we must not disturb the supplies to other structures. So remember the contents. Then you have the lienorenal ligament, which contains the splenic vessels, the tail of the pancreas, again important, especially if you are trying to do a pancreatic surgery and trying to remove all pancreatic tissue. You must remember there is tissue very close to the hilum of the spleen. Then you have a bunch of nodes called the pancreatico-splenic lymph nodes, and their lymphatics and sympathetic nerves. So this lienophrenic ligament is a name for the continuation of the same lienorenal ligament, which suspends the spleen from above. See, it's connecting lieno. The word lien is parallelly it's Greek for spleen, and it is connected to the Greek word again phrenic for the diaphragm. So spleen to diaphragm ligament, and therefore it's because it is diaphragm is body wall. It's called the suspensory ligament of the spleen because it seems to hold up the spleen and prevent it from sagging down under the weight of gravity or for any reason within the abdominal cavity. The phrenicocholic ligament I've already mentioned indirectly supports from below and it's been given a name called sustentaculum lenis. Need not remember it, just remember the presence of the phrenicocholic ligament is a underneath support for the lower border of the spleen to not descend below its level. So again, revision: gastrosplenic ligament containing short gastric and gastroepiploic vessels. Gastrosplenic ligament containing short gastric and gastroepiploic. We've removed the stomach, right? From here we've cut it, and this ligament contains these vessels, right? Short gastric, gastroepiploic. Then we have the splenorenal ligament, which contains the splenic vessels and the tail of the pancreas. This organ is a pancreas, long, thin body, and then the tail is going, I don't know if you can see, it's going till there. So it is contained within the layers of this splenorenal ligament, also contained are the splenic vessels. Then you have the splenicocholic ligament, sustentaculum lenis, which is nothing but a fold of peritoneum attaching to the parietal peritoneum of the left dome of the diaphragm. This is not the best way. This is a wrong name. Okay, splenocholic ligament is nothing but a fold of peritoneum between the mesocolon of the transverse colon and the bottom of the hilum of the spleen, and the phrenicocholic ligament or the phrenicosplenic ligament, which is supposed to be between the diaphragm and the spleen and supposed to be an extension of the lienorenal. So this is the lienorenal. This should probably be called the sustentaculum lenis. I'm not very sure about this labeling. You remember the names of the vessels, and the two most important ones are the gastrosplenic and the splenorenal ligaments. You can mention splenocholic, but phrenicocholic is important from the application point of view. I will come to that. The arterial, all the supplies of the organ. There's a splenic artery, very important artery. If you have the pancreas, the splenic artery is a branch from the celiac trunk which is going in a very wavy, convoluted, tortuous manner along the superior border of the pancreas towards the spleen. If you look at it in this diagram, in situ, the stomach is there. You've had to lift the stomach up and out. This is not the anatomical position of the stomach. You lift the greater curvature up, away, and then you underneath that on the posterior surface you can see that you have the artery coming, and the whole pancreas is retroperitoneal. So the artery is also retroperitoneal. Only towards the end it enters into the double sheet of peritoneum to be able to come to the organ. So it passes with the tail of the pancreas, and at the hilum it divides into 5 or 6 splenic branches. It is remarkably tortuous, which means it is not a straight short artery going directly towards target organ. This is important because it regulates the blood flow to the spleen in different metabolic activities. It permits the movement of the spleen within the peritoneal cavity. It permits the distension of the stomach whenever it is full and empty. The stomach changes in dimensions every time we have a meal. So all that is permissible because of the looseness and the waviness of this, or display the possibility for stretching and coming back to its normal position of the splenic artery. On reaching the hilum, it divides into 5 or more segmental branches. Now, these have been lately recognized. The segments of the spleen were not earlier recognized. If we needed to do anything with the spleen, we had to remove it whole. We couldn't do a partial resection. But now we recognize that there are end arteries, these segmental arteries. Therefore, a localized infarction can be recognized and partial splenectomy can be done nowadays. This is a better picture where you are seeing the celiac trunk coming away from the abdominal aorta, and it's one big branch of the splenic artery which goes all the way and divides into 5 or 6 segmental branches. Similarly, tributaries parallel are the blue splenic veins which form a big splenic vein, which is actually not along the upper border, it will be along the posterior border of the pancreas. It will come somewhere here and form a big fat vein called the, it will join the portal venous system. So we will look at that. So these intrasplenic branches of the splenic artery do not usually anastomose. So we describe it as superior and inferior segments. Now this is a surgical terminology, not an anatomical terminology, where again he's calling it superior pole and he's calling it anterior pole. So then the way the surgeons talk about it is different. But the point is that you have superior and inferior divisions of the splenic artery. In about 1/5 of us, there will be 3 primary arterial branches with superior, middle and inferior segments. This needs to be recognized before any attempted surgery is made, but it makes segmental resection possible. And preservation of splenic tissue then becomes possible. Otherwise, you have to sacrifice the entire splenic tissue even if there is a problem with one small part of it. So venous drainage, it is drained by the splenic vein which passes on the posterior surface. So this is more accurate. The splenic vein doesn't go like that. It goes behind the pancreas. It's behind the stomach, behind the lesser sac, behind the spleen, behind the pancreas. It's exactly along the posterior body wall, right? And it's behind and comes and joins for the formation of the portal vein posterior to the neck of the pancreas. Lymphatic drainage. Now the spleen itself we know is a lymphoid organ. So why would a lymphoid organ drain itself? It would, because it has its own parenchyma and connective tissue, trabeculae. So the connective tissue of capsule and trabeculae are tissue which is drained by pancreaticosplenic lymph nodes along the splenic artery. The nerve supply. Why does a visceral organ need a nerve supply? It doesn't do anything nervous or neuronal. But there will be a sympathetic or autonomic nerve supply to all your visceral organs. So these sympathetics come from the celiac plexus. There's a term called splenic plexus which is loose, not very clear, which consists of these sympathetics plus a left celiac ganglion which is recognized somewhere, and the branch of the right vagus nerve which is also goes through the ganglion but is not relayed. We'll look at nerve supply with more detail later. Visceral nerve supply is a little tricky. It seems to be opposing nerves going and branching together in the same place. But we must remember no relay happens. Sympathetic and parasympathetic stay completely separate from each other even if they appear to be in the same network. So in nerve supply, just remember there is a offshoot of the celiac plexus which supplies sympathetics to the spleen. The development is as lobulated masses in the mesoderm, arising from the mesoderm, and they are in this sheet which you would have already seen called the dorsal mesogastrium. Development of the gut has started, so you know that the entire gut is suspended from a dorsal and a ventral mesogastrium. So in the dorsal mesogastrium double sheet, 5-6 little pieces of splenic tissue start developing and eventually coalesce together and fuse and form a singular organ. Now we've done the microstructure before, so I won't go into detail over here, but at this point when you revise, it's a good idea to go back and revise the histology, where we said there was a capsule, it had trabeculae, and inside there was something called red pulp and white pulp. You remember, white pulp was nothing but lymphoid follicles. All of this is lymphoid follicles, dense aggregations of large amounts of lymphocytes, into which were given branches of the splenic arterioles, which would divide and form straight arteries called penicillar arterioles, and therefore the lymphoid follicles in the spleen would show an eccentric arteriole, and that was one way to recognize it. Apart from that, there was a whole lot of vascular tissue which was called the red pulp, not seen in this picture. So we had these sinusoids in the red pulp, surrounded by a loose capsular sheath, and then you had the arteriole would divide. It would be surrounded by this dense aggregation of lymphocytes. You look like a lymphoid follicle, and as the blood flows through it and gives branches and flows through it, right? It seems to be surrounded by a periarterial lymphoid sheath. Remember, PALS, PALS, and then it reconstitutes back into a venule and goes back into the venous drainage. So this is the idea of closed circulation of spleen. And the other opposite idea is that it goes and all the RBCs, WBCs, everything spills out into and between everything else which is happening in the spleen and reconstitutes back as a venular tributary. This is called the open circulation plan. I'm just revising it here because you've done it before, and it's good to know. Now it's accepted that both kinds of circulation properly operate together depending on the metabolic demand for dealing with whatever is coming in through the blood. The functions, it is best described as a sophisticated filter which monitors and manages blood cells as well as immune functions. So it does early hematopoiesis, I have talked about it. It does filtration of senescent, means going to die, aging erythrocytes, and it is very important in infection control. So if there are pathogens within the RBCs such as malaria pathogen microorganisms or Bartonella, then they are killing off the RBCs, and the spleen mops up the victims of the fight and clears off both the RBCs and the dying WBCs. That's its function as a lymphoid organ. It also clears unopsonized, non-ingested bacteria from the systemic circulation, and any microorganisms which float into the spleen through the blood, which we do not produce a specific host antibody for, will be engulfed by the splenic phagocytes. So these are important reasons why we need a spleen, and it should be there, which is the basis of trying to have a conservative surgical approach to the spleen in today's medical practice. Splenomegaly is a very important sign which shows up in your patients. So for some reasons, the spleen may become enlarged and palpable, but it won't even be palpable until it will become 2 to 3 times of its normal size. So there are infections, there are anemias which can cause an enlarged spleen. It will grow downward and medially because the phrenicocholic ligament prevents it from growing directly downward straight into the left lateral and left inguinal regions. The splenic notch will be felt through the, if you palpate the patient's abdominal wall, you'll feel some solidish organ and something which feels like a border, and it's not looking like a smooth line but like a notched border. That indicates that organ which you're feeling is probably the spleen. Injury to the spleen is common, especially if there's going to be breakage of the lower left ribs, such as in automobile accidents or in sports, or if there's a penetrating wound with a knife or any other object. Even in blunt injury to the left side upper abdominal wall, even if there is no outside appearance of a break, and even if there is no clinical picture of a fracture, the spleen may have got bluntly damaged. It's a very soft organ and very bloody organ, so it can get very easily contused. That kind of injury is called a contusion. The surface is not broken, the capsule of the spleen is intact, but inside some crushing has happened. A tumor can happen in the spleen for various reasons. It could be splenic, or it could be from some retroperitoneal organ such as the left kidney. How we differentiate is by percussing. We tap on the anterior abdominal wall to try to get a sound from the contents of the abdominal cavity, and always we have the loops of intestine and the colon more anteriorly placed. They are bulging up. So, and they contain gases which are products of digestion. So we'll get a tympanitic note or a more resonant note if the structures are, if the organ which you're feeling is behind those loops of colon. On top, when you do the percussion, you're going to get a tympanic note. So when the spleen is enlarged, the colic flexure is displaced below. So you won't hear the resonant sound, you'll feel a dull sound because it will be right on the spleen. But if the kidney is enlarged, it does not push, it's retroperitoneal, it cannot push the colon out of the way. So the band of resonance of colon is always elicitable just anterior to the spleen. And this may sound a little Greek and Latin to you, but remember that to differentiate a intra-abdominal mass which is enlarged in the left hypochondrium. If it is spleen, you will not feel a resonant, you will not hear a resonant band, you will have a dull sound. If it is not spleen but a retroperitoneal organ like the kidney or the pancreas, then you will have a resonant sound. The colonic resonance is elicited over the mass. Because of its development and because of the way it is positioned in the abdominal cavity, it's a loosely hung organ, but tucked up against the left dome of the diaphragm. There is no reason why it should not fall down with levity, except that the intra-abdominal pressure keeps all the organs pushed against their periphery. So the stomach and the colon, they keep the spleen pushed up against the left dome of the diaphragm. So the accessory spleens may happen because they are being formed by fusion of several separate pieces. 10 to 15% of us have it, and where they will be found, they won't be more than 2 centimeters usually, any one of those pieces. So at the hilum, in the lienorenal or gastrosplenic ligaments is where we can find these accessory spleens. If the peritoneal attachments which we talked about are not formed very well, then you will have an unusually long splenic pedicle. The double sheet, instead of being short and tight, is long and allows the spleen to hang a little more free, which is why the spleen may wander out of its comfortable niche under the left dome, and it may get exposed or abut on other organs. And if that long pedicle is twisted upon itself within the abdominal cavity, that torsion of a vasculature, because the vessels are inside it, is an excruciatingly painful phenomenon, and it's an abdominal emergency, and the patient may complain of episodes of abdominal pain because of the torsion, and then it will release again, and the tension in the pedicle. So we require a CT scan for diagnosing this, and we probably do a angiography. So if you get the dye into a splenic artery and you don't see the contrast enhancement, it means the blood is not going to the spleen because of the long pedicle, probably. It's a little difficult thing to diagnose what exactly is happening, which organ could it be which is causing this abdominal pain. Congenital asplenia can happen. Just as you can have several accessory spleens, you can also have the absence of any splenic tissue altogether, which is a genetic disorder. It's associated with abnormalities of other organ, in which case it will cause death in very early infancy. So it's because of the absence of a Hox-Levin gene, and obviously it will cause a decreased immune response, an absence of spleen. Splenic rupture is more common as a result of trauma, road accidents, traffic accidents, industrial accidents. Then a pain to left shoulder may happen in the patient because of the irritation of the left dome of the diaphragm, because of the blood clots. The spleen has ruptured under its capsule, or its capsule has also ruptured, and blood has clotted, and that will touch upon the peripheral parietal peritoneum under the diaphragm and be interpreted, referred pain as pain to the left shoulder. The other thing which can happen is on the left side there is blood, and the spleen is, because it has oozed and it has clotted. When you percuss the abdomen, you feel a dullness throughout. But on the right side, if you ask a patient to turn, the dullness shifts, and you can get a resonant sign if the patient turns. But on the left side, even if the patient turns, the dullness doesn't go away. You don't get a resonance. That is called Balance's sign. This kind of splenic rupture can cause death because of continuous internal hemorrhage. It must be diagnosed very quickly and dealt with very quickly, and usually the measure we take is immediate splenectomy to save the life of the patient. So in splenectomy, what do? Basically, we remove the whole spleen, either because it is damaged irretrievably, or because it is diseased in some process such as leukemias. You've heard of leukemias, lymphomas, certain massive parasitic infections, or repeated chronic infections, which make the spleen unhealthy and vulnerable to injury because it has got enlarged and it is not going to go back to its normal size. So then we do a therapeutic splenectomy to remove that as a problem for the future of the patient. What do we have to do? We have to open the abdominal wall. We have to open the abdominal wall through a supraumbilical, usually a midline incision. We can also take a para umbilical or para midline incision. You surgeons usually prefer a big one because they will be wanting to explore the whole area and mop up anything uh, extraordinary happening inside the abdominal cavity. A lacerated spleen will be spilling all over the place, so it's good to have a larger area of access. And then you put in the retractors and you go in and you try to catch the bleeders first, right? And you catch hold of the vessels which are getting in through the gastrosplenic and lienorenal ligaments. You be very careful not to damage tail of pancreas, not to abut on the kidney, any of the other structures, and the lacetate tear which has been bleeding. So this is one way to do it, and then we clean up all the blood spilled into the peritoneal cavity, do a lavage and wash it out and make sure that everything remaining behind is safe and in its proper anatomical place with all its supplies intact. But like I mentioned earlier, because now we recognize vascular segments of the spleen, we may choose to do a partial splenectomy, only take out its upper or its lower vascular segment, or in the rare cases where there may be 3 segments, we may try to conserve 2 and only remove 1. But it's a delicate surgery, it requires a gastrointestinal surgeon, and it requires sophisticated equipment to be able to do that properly, because you have to suture back the laceration of the capsule with a microsurgical technique, and keep the spleen back and make sure that what you're remaining behind has its own blood supply and all its supplies are intact. So you can't do a block clamping of the vessels. You have to do a selective tying of the vessels. Always arteries are tied before the veins to control the bleed. So there are surgical techniques, certain things, but what you need to remember is splenectomy in today's medical world is possible to do a conservative or a partial approach and do a partial splenectomy also. This was not possible even a decade ago. So that's it. As far as the organ called spleen is concerned, it's easy, practical to have if you get that in your exam. We'll show it to you in the tray and in situ in the body along with all its relations once you come back to college. So we'll stop here and we will go on to the next class next week. I'll see you. If there are any doubts, please raise them in the chat box, share it to the IT admin and they will pass it on to you. Thank you and have a good weekend.